Hey, where's the other blabber? Hey, we'll appreciate the quiet. Okay, so without further ado, a couple of things that I have to report on. One, Dr. Robbins and I have finally come together. So if you have Lab at 3, you'll see me doing a demo on some technology. I'm sure if you want to come, we will make room. If not, we'll find another lab. We'll figure it out. Not a problem. Okay, so that's first on our little list of activities to be able to show you. And basically, I'm starting today's presentation. This is the Cowan one. This is the one that's in your textbook. But there's a couple of good, I want to do a little definitions before I get into the meat of today's to start examining the antibiotic categories and how they work. And we'll try to get through as many of the cell wall, probably hopefully get through all of them today because they're really, it's the main line of therapy. And this is, we talked about this, but today, this is just to reinforce it. This is the post-antibiotic era, where we really are. It's scary for me. Imagine what it will be for you, and if you have families or kids and grandkids. So this is what we try to do to find something, but there's no perfect one that exists. Administer it, gets where it's supposed to be. Toxic to the infectious agent, non-toxic. It can't happen. We don't have anything like that. Active as long as needed. None of this. This is the ideal agent. You'll learn there's very little in the way of ideal. Again, penicillin might have been the best of this because because it targeted something, but the allergies came in. Relatively, it stays in solution, potent, doesn't lead to resistance. That's never going to happen. It, works with your body's defenses, active, delivered to the site, doesn't have allergies or other problems. Sorry, can't got that. So based on that little discussion, here are some of the terms. Prophylaxis. I used to do a whole number on this. We don't give prophylactic antibiotics. In other words, prophylactic means preventative. Under certain occasions, if I operated on a lot of diabetic patients, if you're operating on diabetic, they're prone to infections. That's a reason. If you're using multiple surgical incisions, sometimes we had to do that. That's a reason, a risk of infection. Somebody with a pre-existing condition or has had infections previously post-operatively. But if you're going in to get your knee scoped, pretty common procedure for a lot of people, doing a little cartilage repair on a medial meniscus, medial meniscal tear, you're not supposed to get antibiotics before, and you're not supposed to get antibiotics after. That's part of the years ago. I better give them some antibiotics just in case. A lot of it was liability generated, and particularly as people started suing doctors more, they got scared about this. So it's not just them. And people, why am I not getting antibiotics? The problem is, if you don't need them, we didn't need to prescribe them. But people didn't learn that lesson, and maybe doctors didn't learn that lesson. I hate to be preachy about it, but it's absolutely true. Moving on. Antibiotics. Again, natural. That's what makes the bio in there. Inhibit or destroy. We prefer destroy. Generally, the term is used for drugs targeting bacteria and not other types of microbes. That is correct. You're going to see there are some naturally occurring substances, but they're not. If they're not in this category, we do not use the term antibiotic. Semi-synthetic drugs. I commented that in a little bit. They basically means we take something, we take a naturally occurring one and we tweak it in the laboratory. And you're going to see, you don't have to know the chemistry. I do not want to have a mass exodus from the class or a revolt. So I do find you a little revolting. Groucho Marx. Just go with it. You could have laughed a little. Give her one of these. Wake her up. Okay. So we tweak it in the lab versus they're totally made. Effectively, the antivirals pretty much are totally made in the laboratory. So no, there are no antiviral antibiotics. And then the spectrum means how wide or how narrow. Effectively today, if it is only on one, today's definition, it's either gram-positive or gram-negative. That is limited, or effectively that's their range. And if it's broad spectrum, it hits both. The trouble is broad spectrum causes broader problems and more side effects. So bacteria or fungi, competition, usually these are the players. And so we're going to certainly look at penicilliums and cephalosporians, and they bear their name. We call it penicillin and all the other kinds of penicillin. If you're allergic to penicillin, it means you're likely allergic to ampicillin, amoxicillin, not cloxacillin, dicloxacillin, methicillin. There's understand that's important. Part of this discussion we talk about are what are called drugs of choice. When someone's allergic to penicillin, the drug of choice nowadays is probably the Z-Pak. It's something in another category that we'll learn about called macrolides. I mean, drug of choice has a lot of connotations. In addictive disease medicine, when you if you ask someone with their drug of choice, they'll say heroin or cocaine. That is an addictive disease thing. Drug of choice is a very significant. You're going to learn about this. Many of you could go into clinical fields. It's we call usual, customary, and reasonable. And another term we use is standard of care. It means you don't use what the drug of choice is for a particular problem. You better have a darn good reason. Like, oh, patient's allergic to it. Gotcha. Good choice. You see what I mean? And you're going to, you don't want to ask, well, isn't this the accepted procedure to do this? Yes. Why didn't you do that? You don't want to be sitting there in front of a bunch of people asking you those hard questions. Really. So, I mean, you need to, if you have a good reason and you've cleared it, I mean, so many of you, if you're going to have to go to a supervisory or for many being a nurse on the floor, and you go to the doctor and they go, I want to start this. Okay, well, I have a question because of this. And the doctor says, it's okay. Put that in the chart. We have an expression that you may have heard, and I will reiterate it more than once. It's called CYA. And you want to see why you're posterior at all times. That's what charts are about. The only thing between you and having a session with one of these people who take no prisoners, and they do, is that chart. So, and you have to, and this is what we should do. And you did those things. Many of you had lab yesterday, and you started to look and you measured in the Kirby-Bauer, the SINR, and all that stuff. Was that fun? See, did you have Pseudomonas for an unknown? Oh, not unknown, but nothing works very well with that. Not the stuff we have. So all of these things, I don't want to rebuild the wheel. Identifying it, that's what you did in the lab. I talked about making an informed guess so you could start. And this is what I used to do, and we all did this. You get an idea of what's going on. You learn that fast. In an emergency room, hey, we got to start them on something. Because understand, an emergency room, particularly in a city like ours, if you're watching the pit, and it's the same thing, you don't know if they're coming back. So you try to make sure you treat them so they'll be able to come back rather than be something you don't want to have happen. Okay, and a lot of times you have to, you kind of get a feel, is this a chronic user, or, is this somebody, we don't get some medicine in them now, there's a good chance something really bad's going to happen. All of this goes through your mind. That's, if anything, I'm trying to give you my benefit of my clinical judgment. And even though it's 50 years ago, it hasn't changed that much. People are still pretty much people, Rules may have changed, the medicines may have changed, the severity may have changed, the environment may have changed, but no. Okay, and we're going to test, and we'll get into some of those, and that was the Kirby-Bauer, and we're done with that. Back to what I want to talk about. So as this goes back from the textbook, the Cowan PowerPoint, back to the Nestor PowerPoint that they were using, it's where we left off. The biggest category, I'll back up just a little bit. I backed up too much. All of these cell wall antibiotics. You need to be, I'm not telling you need to know everything they're saying in here, but you have to understand the major category that we use more than any other are called beta-lactam drugs. It has to do with you'll see it. It's another structure. It's a ring structure that actually inserts itself in a way that prevents peptidoglycan from being assembled. No cell wall. Good things. That's the pivotal piece. This one category alone, cephalosporins, more than half of all antibiotic prescriptions are written in this country for cephalosporins. And I say this all the time when many of you are going to have to learn a lot about different meds and all sorts of pharmacology. The ones that you use constantly, you need to know the most about. When to use them, what they mean, what are they all the same, all these names, and they're not. Understand, that's what this is about. Trying to give you a background for something that's going to come at you fast and furious in less than a year. So, cell wall, unique because they contain peptidoglycan, great target, high therapeutic index. Why do we have to have allergies? But we do. They come from mold, and people get allergies from mold. This is the ring. It's a structure. I don't want to go into the chemistry of it, but you can. There's not a whole lot of difference. You got the main structure. You got a side chain here. You got another side chain here, and these are where we tinker. You see where those R's are? That's where we can tinker with these things. That's where we start to use these semi-synthetic things. So they all have the beta-lactam ring. They competitively inhibit. In other words, they kind of get involved with enzymes so that you can't assemble it. That's all you have to know. It interferes with peptidoglycan synthesis. Okay. There's a fancy name that is very confusing. I don't use it. They're called penicillin binding protein. We named the protein, okay, on the bacteria for the drug that attacks it. That's because penicillin was the first one. You don't have to know that because I found it very confusing. However, think of what bacteria can do. They actually change this protein from mutations or adaptations to being clobbered with penicillin for the last 80 years. And that's where MRSA comes from. It actually changed its own protein. It mutated a protein that penicillin attaches to. Not bad for a single-celled organism. Okay? And it's only effective against, that's fine. If the cells are dead, we're not worried about them. So here's what happens. If you pop the cell wall, they get ready to explode. The cell wall weakens because there's always fluid. If there's an infection, inflammation, fluid comes there, pop. Okay. We saw that before. So we don't have to know where it attacks here, or Vanco, or bacitracin, don't care. I'm sure you want to forget about NAGs and NAMs. I'll stop nagging you about the NAMs. If you don't respond with an appropriate degree of laughter when my boss is in here evaluating me, I will look bad. Fake it. It's okay. I can take the hit. So, peptidoglycan, cell walls, gram positives, it's exposed. The outer membrane blocks a lot of these. Okay, and understand those binding proteins differ as well. They differ if they're aerobes, they function in the air, or anaerobes. All these things. Here's what they did as time started, without reading this. As they were being assaulted with penicillin, staphylococcus, and root staph, and others, began to secrete these agents, and we have two names for them. They're not the same. I'm not trying to say they're of less equal importance. Maybe today, the importance have changed. They made some, and they both target the beta-lactam ring. They don't, typically they make one, not the other. One is called penicillinase, mostly staphylococcus. One is called beta-lactamase. They named it for what it attacked, or the molecule that it attacked. Mostly others, like strep, some gram negatives. But there's some staph in there too. When we talk about wound infections, particularly like dog bites and cat bites, that's a kind of staphylococcus that actually is a beta-lactamase producer. You won't have to know that now. You're going to have to know that for the final. Just to give you some idea. And again, I have a lot of experience with that as well. So resistance develops because of this continuous exposure over time. Mutations, we talked about that, genetic modifications. So we describe these as penicillinase resistant staphylococcus, or we talk about other bacteria as beta-lactamase producers. They give us a problem. So over time, that's where the technology started to come in more advanced today than it was, and we begin to see that. This is the basic structures. These are the original penicillins that they talked about that Fleming couldn't isolate, but the two scientists in 1940 did. They came up with penicillin G, which is even still used occasionally today, and penicillin V. They are the originals. The difference, and it's a consistent thing we see with a lot of antibiotics, sometimes you have to tinker with them to make them more resistant to stomach acid. So this is better by injection. This is better orally. And that's true with a lot of it. Orally is a lot easier. Now, I haven't, in the last, when I had a dental extraction done 20 years ago, my dentist gave me Pen VK, which is the penicillin V, because you're worried about streptococcal infections, and you'll understand this for most streptococcus. If you show them the label of an antibiotic, they die. It's like, oh, I'm gonna die. I used to fall down on the floor, but it's too hard for me to get up these days to do that. Believe it, I did do that. It's 25 years ago. I could get back up. The dog puked yesterday morning. I'm trying to get off my hands and knees. I got to hold on to stuff. He got a bath. Okay. Continuing. So for penicillinase producers, they said, we're going to tinker with that side chain some more. This is all the one side chain. And we're going to come up with this thing called methicillin. It's going to be for penicillinase resistant staphylococcus. What happened, okay, that was better injection. These were orally. So these became orally active. Well, oxacillin, there's got a zillion names. You look at that family tree I showed just in this PowerPoint. It just means it's more resistant to acid. So your stomach acid won't clobber it. We were using this a lot. So back in the I started to hear about it in the late 60s to early 70s, particularly the early 70s. This is what was troubling us with staphylococcal infections, which, by the way, are still public enemy number one when it comes to infections in wounds and in hospitals. Period. End of sentence. Okay? Got it? Naturally occurring. We get this stuff from a penicillin, red mold, very narrow in spectrum, only easy to kill gram-negatives. Penicillinase resistance now everywhere. So now it's been altered again because it morphed again, okay, produced altered penicillin binding proteins to which it couldn't even attach. And hence that was the next step to become methicillin resistant Staphylococcus aureus. And we have nothing in the original penicillin family that effectively is effective. They've tried a lot of things, but once it got to be MRSA, penicillins basically didn't work. Now, they knew penicillins were good, and I told you this before. All they did was they tinkered with it a little bit. They added this side chain that had an amino group. Great, of ampicillin. We originally took it by pills. Now they found out, again, it's much easier to tolerate orally if you modify it again. So orally active aminopenicillin came the term amoxicillin that most of you are familiar with. And it is used all the time for people who aren't penicillin allergic. You'll learn when we talk about respiratory infections why we do this. It's very, very effective. You may say, oh, I had to take this or I had to take that. Understand it's still the first drug of choice for people who are not allergic to penicillin. That's important stuff to know. Are any of these a substitute that works on MRSA? No. And then these are more exotic. You don't have to know the names. This was particular. I asked why I mentioned Pseudomonas. These are really different organisms that make these somewhat exotic beta-lactamases, and they're very hard to get after. The drugs that can get after them cause tremendous side effects. So they know penicillin had less side effects other than allergies. So they really, but none of these are panacea. None of these are great. And that gives you an idea. All right. So side chains are modified, as you can see here. Broad spectrum against gram positives and gram negatives. That's when we started. That's by broadening the spectrum. That was the ampicillin and amoxicillin. Extending it, particularly against Pseudomonas. Okay, didn't work as well against gram positives, but and unfortunately was destroyed by a lot of beta lactamases. So here we came up with something. Well, beta lactamase is an enzyme. So if you could target efficiently that particular enzyme, so if you found something that could block beta lactamase, this penicillin typically would survive. And so what they did is they found something that targeted it. It's an antibiotic called it's very specific, clavulanic acid. So they took amoxicillin, which didn't work well in presence of beta lactamase, and added. This is one of those synergistic effects. Two together work better. Clavulanic acid, and they gave it a very famous name that you should very much know. Because by sort of high powering it or bolstering it, it came up with a name. You have to know that called augmentin. You've heard of augmentin. People make the mistake to say, oh, it's strong. It really isn't. What it does, it's very useful if on one of those Kirby-Bauer tests, you're able to identify beta lactamase producers. You know what to do. I'll even tell you about it before you get to the hospital. Because the clavulanic acid effectively kills that, and then the amoxicillin can work. Happy days. That's those kids, they were on that's the second week of amoxicillin. We've had it for 10 days, nothing's happening. Okay, and then you need to go to work. Why don't we use it all the time? GI. Clavulanic acid, they started adding it to the drug of choice, which is erythromycin, which is already bad in stuff. And I mean, and he started to add it to all sorts of things. He found out that it was horrible diarrhea, horrible GI distress. And so you had to limit what you could use it with. I prescribed it a lot. And when you have, because I have a lot of these kinds of infections, and what you have to do, you start them on probiotics, yogurt, whatever. You immediately figure it's not going to go well. Start taking this stuff right away. And you got to tell them, and you got to document that, because it's sort of it's important to do sort of advanced scouting and advanced notification of possible side effects. This is the best antibiotic, but this is the side effect. Let's take steps to do it. Okay? And I mean, with little kids, Go-Gurt and all that type of stuff, just don't do the routine. They don't care, Lou. Thank goodness. The single most important category, just checking, that I can tell you about, the cephalospores. They are a similar mold. These are all over the place. If you see mold on something, very often that's kind of black. More often than not, in foods and things like this, probably cephalosporium. So this is the name of it, Acremonium cephalosporium, which you don't have to know. Fungi have wonderful names. I love it. So it includes closely related group from Streptomyces. Remember, Streptomyces is not, it's a soil bacteria, but what's interesting, the way it replicates a little differently than regular bacteria. They kind of make things that look a little bit like bacterial spores, but not endospores. Don't have to know that. Its structure makes it resistant to some beta lactamases. Some have low affinity for penicillin binding proteins of gram positives. And so, and you'll see that we have multiple generations of this. So why do we use the one you'll hear the most about? One called cephalexin and one called cephalosporin. You're not supposed to use these, but here it's called peptides. Both world. And this is called sequence. This is a first generation. I mean, one of the original ones they developed, and this is the second generation. It all has to do with that. There's 4 generations. They're talking about that PowerPoint during that one. Fifth generation they're working on, as well as the fourth, which I'm tinker with these to make them more desirable for treating MRSA. So it's not like they gave up. Why are they better? Okay. Right. Okay. They are better than penicillin against gram-negative. They are less, as the PowerPoint says, they are less likely to be deactivated by their blasphemy. Already that's 2 perfectly good reasons. There is, unfortunately, and there the cost, and I'm trying to consider cost, but now, unlike when I started prescribing them, they were very expensive generics. We live in an age where there's a lot of subsidies for people depending on health insurance and prescription. That's relatively new. I started. I am this lady, I had one of those patients, 30 million. She was 85 then. I think I treated 4 generations of her. And she was one of those ladies who was weighed less than her age. We happened to shop at a little supermarket in Oil City, IGA, Independent Grocers Association. I don't know if it still exists. We're in there. I really good person. And we're shopping. I see her in there. I say hello. God bless my ex. She was great like this. I mean, we bought a ton of stuff. I said, what are you doing? She goes, I'm shooting to it. We'll help her carry it back to her. So imagine me giving this lady a $40 or $50 prescription for, think she's gonna get that or she's gonna buy food? You don't think of it today, but it's absolutely true. Generics are available now. This is broadly speaking affordable. Copays are insurance. Things that are problem. This is a penicillin relative. So if there's a 10% equal cross reactivity, you're allergic to penicillin. You don't use any of the penicillins, but you have to make sure you don't want to use any of the cephalosporins. And 10% is a big number. If it was 0.001%, you wouldn't worry about it so much. Somebody could die from anaphylactic shock. So 10% cross reactivity. Here's what I had. My favorite patient, no longer with us, diabetic. He had terrible infection. I have to use antigens before he really got worse because I'm allergic to penicillin. I'm like, oh my God, he needs this. It's a staphylococcal infection. Here's what I did. I called up his diabetologist, internist, and said, because he told me, well, I'm taking Keflex. I said, hey, he's here. He's here. Tells me he used Keflex. No, he says, so he says, yes, he's happy. So I documented it. Go to Dr. So-and-so, blah, 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 blah. Patient can tolerate Keflex. You can do it. Drops in the eyes, replace the allergy test. It was so important. I had a weapon to be able to deal with a man with acidosis. Allergies, 10% cross reactivity. These are negatives. Everything else is positive. Cross reactivity with PCN and so on. That's an issue that's there, and some of them are more difficult to tolerate than others. That's really the big setback. So that's why more than half the infections is better against gram-negatives. Somebody comes in with one of the, a deep wound, kind of dirty, you clean it out, put some stitches in, put them on Keflex. Not allergic to penicillin, fine. See what happens. That's why more than half the prescriptions. That you need to know all about those and all these other names that popped up. Okay. It's so, and you can go back and look at all the names if you want, and you're going to see them routinely. When I did use prophylactic, I use what we call perioperative antibiotics. Probably still used today. Last time I operated 25 years ago, we do it by you start somebody on an IV. I used Keflin, which was the intravenous form of these, which we started to administer as when they started the IV for them to go into surgery. We ran a gram of that, or however much it was, and then another gram in recovery. So that what happens is now it's in all that fluid that goes when you operate goes into a wound. It's called a ceratoma. It's laced with antibiotics. Because I'd be putting a wire, a pin, a screw, some type of internal hardware in there, and that's a justification for postoperative antibiotics, because those things get infected, even though it's just sterile stainless steel. All of these things. Oh, love this stuff. Later generations more effective, and you'll see them. I'm not gonna. This is kind of the stuff they're gonna give you. You be afraid. Be very afraid. Nowadays, we stopped using these. Okay, as Trianam had terrible side effects. Now it's become a go-to against entero. It's an important name. Do you have any idea what Enterobacteriaceae means? I don't see anybody here. Entero means what? Enteric, gastrointestinal, digestive tract. And parenteral means when you make something enteral, they can swallow. Parenteral means alongside of or another root. So when they talk about parenteral medicine, you have to inject it, you have to inhale it, whatever. Okay, intravenously, intramuscularly, etc. Enterobacteriaceae are enteric bacteria. They're in your gut. Okay, they are a real problem when they are very resistant to a lot of medications. And these are the kinds of ones when an appendix bursts. These are the kinds of ones when cancer ruptures an ovarian tube, okay? Something leaks because of diverticulitis, a little hole in the large intestine. It happens all the time. So now we're starting to use these more, but it has a lot of side effects. So you're going to learn about it as Trianam down the road. Drug of last resort, very slightly different, okay? It's absolutely only used, called Vanco or vancomycin. Got to know about that. It does not under any, every time they've tinkered with it, nothing gets through the gram-negative outer membrane. So it's absolutely contraindicated. You cannot use it, and you will not use it for gram-negatives. Binds to whatever it binds to, weakens the cell pops. It's almost always administered either intravenously or intramuscularly, because it doesn't, digestively, it is awful. The only time we used to use it, you've all heard about C. diff. C. diff and this other guy play ping pong. This is a kind of streptococcal cousin. They play ping pong, getting people sick. Does the name VRE ring a bell with anybody? Your readings, you're going to see a gut strep called enterococcus fecalis, because it's in the colon. So when people used to get diarrhea in the hospital, they instinctively said, "Oh, we can just give them this vancomycin because it goes right through the gut; it doesn't get absorbed that way. We'll treat it." So it became resistant. Vancomycin resistant enterococcus. So what happened was you treated that, and what broke out, you treated that, VRE, and got rid of that, magically you paved the way for C. diff. Ping pong, particularly in nursing homes and long-term care. The only time I had to take that before they do gastrointestinal surgery, they do a thing called sterilize. It isn't sterilize, it was what they call it, the gut. So they give you a bunch of these powerful antibiotics that are just going to give you the world's worst diarrhea because they want to clean it out before they operate. So it lowers the risk of when they have to go in there and cut half your stomach out and reroute it, which I had done not once, but twice. You know, I'll be at the gym tomorrow, working out, headphones in. Moving on. So we can't, and here's the other anecdote I always tell you. You may think that someone, I was licensed to prescribe medicines for more than 25 years. The antibiotic, it didn't matter what I had, it's unlimited. Narcotics, controlled substances, anything you had a reasonable right to. Me prescribing birth control pills would have been inappropriate. That was not my field of endeavor. But about anything else, probably. Psychiatric medicines, not appropriate. You would think a doctor could write on a chart, give this patient vancomycin. Doesn't work that way. Here's what happened. I can recall it like it was yesterday. I was doing it where the Penguins got clobbered last night. An ugly game if you watched. Okay. What happened? That used to be a hospital called Central Medical Pavilion and then St. Francis Central. I operated out of there for 10 years. I walked in there, I think it was 94. I'd already been operating there for 4 years, and it was a thing, you must read and sign off all doctors in the doctor's dressing room. Because it just, and it said, we will no longer fulfill your prescriptions for vancomycin unless you can document that you've used at least one, if not two, types of alternative antibiotic therapy. Even then, they realized they were creating a monster. You're going to learn about it. It's called vancomycin. Now we have MRSA. We have started to develop VRSA, vancomycin-resistant Staphylococcus aureus. After that, we have SOL, Staph aureus. So you had to document, and I'm going to show you the pecking order, probably not today, about the way we did it. And basically I learned to do it. I went to a lot of conferences, all doctors do for continuing education, and say, okay, what are we doing? Okay, what are you doing for MRSA? What are you doing? Did this work? Did that work? And this was the pecking order. Because if you can't document that, and it isn't just enough to say it, you got to show it. You know, here's their chart, or I will, in those days we faxed things and things like that. Technology was different. Or brought them to the hospital and made a copy at a photocopy machine and brought it to the hospital. Okay, just stuff like that. So, I signed off on it. Thankfully, I never had a patient with this. I had one guy with a bad infection. Thankfully, I got an infectious disease consult, and they took care of the problem. Thank goodness for that. So, bacitracin, topical antibiotic, part of triple antibiotic. You can buy it by itself. Can't use it inside. Just nasty. So that's all the stuff. Well, as we get to it, and I'll write it anyway. Down the road, when we get to these things, the pecking order for me. This is my first line, combination sulfur. This is in the hospital. For MRSA. 2, these are cool. You're going to learn about it. It's called clindamycin. It's got a lot of side effects. They're around for a long time. 3, newer agents. The one I like is called Sinercid. And then finally, Vancomycin. Sort of the pecking order from start here. It doesn't work, keep going. And now, again, there's constantly in the pipeline. When you hear the term pipeline in the hospital, it means typically pharmaceutical companies making stuff that are going to be used, and you're going to need to be familiar with them. learn about them, look what are the potential side effects, things like that. That, thankfully, is the largest category. Other than this, there are two, rather. I misspoke. Protein synthesis. You don't have to know what ribosome. Is it 50S? Is it 30S? Is it here? Is it there? Don't care. Just know that it inhibits protein synthesis. Again, when you have a lot to memorize, and I said this before, memorize exceptions. Memorize penicillins, cephalosporins, vancomycin, concentrations topical, astrianam. Now we're just using it. A couple of other, and then the default probably is, because there's more in this, is protein synthesis. So if you're stuck, again, if you're stuck on it, that's why you do this stuff. So you don't sit there and this is no knock, because many of you have come to me with this. You just spaz on the tests. You do. You're entitled to. You're young, and you're starting to see the degree of importance that this stuff has. Thank goodness, I understand. Pardon me. So, all cells make protein. So if we can, the trouble is our cells have those 70S ribosomes. That's the problem. Prokaryotes have 70S, eukaryotes have 80S, but we have mitochondria. And it's good to use a permissive term like may. We don't really know. So you're going to look at these, and I'll give you a little backstory, and particularly on the ones you have to know that are there. They all play an important role. What I did not talk a lot about with any of these were toxicities previously, because the cell wall targets peptidoglycan. If it's bad for you, and some of them will be, they'll give you diarrhea or stuff like that, but it's the big problem is allergies. Now we're getting to the big problem, are side effects. Read that as GI. Not all, but read that. So the aminoglycosides, that was that Selman-Waxman guy. That was streptomycin. So what it does here, here's some limitations. The gut bacteria like enterococci, streptococci, anaerobe doesn't mean, so you already have limited bacteria. Interestingly, down the road, we're going to look at tuberculosis medicines, pretty important. Requires some type of respiratory metabolism. So it can be transported in. Sometimes we use it with the beta-lactams, which allows it to enter the cells. We used a lot for bad infections. We used to use these in combination back in the day. They are not necessarily a favorite category, but Pseudomonas is coming to the party. So often toxic, generally used because they have two toxicities for people that and the drug of choice, as far as I'm concerned, nowadays, even though they may tell you about some others, something called gentamicin is in this category. It only works by injection. Okay? That is in this category of, you can see they're called, and again, it's about categories. Aminoglycosides. It's one of the few agents we have. Pseudomonas is an aerobic bacteria. So it's not one of those other ones you're hearing. That's why it works. Pseudomonas aeruginosa. Extraordinarily problematic in us. Extraordinarily problematic in burn patients. Burnt skin and tissue are comfort food. No other way to say it. It's like the perfect medium. There's Thanksgiving, open-faced turkey sandwiches, mashed potatoes, gravy. For you that don't eat, big problems. Renal toxicity hurts your kidneys, and ototoxicity hurts your hearing. You always have to monitor those two fun. Kidneys easy because you can do blood tests a couple of times a week. Okay, we know if somebody's got a problem here. Oto is different. It's almost you have to monitor hearing, and particularly in an elderly patient, they may have hearing difficulty. Younger patients a little bit, but these are bad side effects. So sometimes you have to pick. Pseudomonas infections are very hard to treat. Sometimes it's better off. Yeah, sometimes that's the criteria. Okay, tobramycin, which is another one of these, they're using because Pseudomonas and cystic fibrosis patients are already in trouble because they have abnormally sticky mucus. It's very hard to get a chronicity, if that's the right term. It's a lot of respiratory and digestive infections. So that's unusual. If somebody's getting respiratory Pseudomonas, this is someone in trouble. I will start here with the tetracyclines. I don't want to give it short shift because you've got to know about the side effects. Thank you very much. Wonderful day. So maybe I'll see some of you doing my demo in lab, which I will need volunteers for. So if I recognize you, I will volunteer you. You're not in that lab. All you have to do is breathe. You know how to breathe.